it's my pleasure to introduce Emily Kahnert. She's a physical therapist in the Temporomandibular Disorder and Orofacial Pain Clinic at the University of Minnesota School of Dentistry. She completed her Doctor of Physical Therapy degree in 2005, and she was interested in working with performing artists at the time, but then became interested in orofacial pain, and she's been practicing orofacial pain almost exclusively for the last 17 years. So she's got a whole host of experience working with orofacial pain populations, and it's my distinct pleasure to have her come up and share some of this knowledge with you all. Thank you.
Hello, welcome everybody. Quick question before I get started. Has anybody here ever had physical therapy? All right, a few people there. Of those who have not had physical therapy, how many are familiar with PT as a profession? All right. How many people in here knew that physical therapists can work with patients who have TMD or orofacial pain? Okay, good, good. Actually, there's this study that looked at dentists in Florida and found that a very small percentage of dentists in Florida knew that physical therapists can treat people with orofacial pain. So that's already very exciting. So yes, I started working with this population. I had a clinical experience when I was in PT school and really loved it. I, as Dr. Boguero said, was interested in treating performing artists, so I thought, hey, I'll do this clinical at the TMD clinic and get some experience that'll help me with treating singers and brass players. And sort of fell in love with this area, and then after working for a year, started at a private practice in Minnesota where I was exclusively doing this, working alongside dentists, health psychologists, and neurologists for most of my career. So I came back to the University of Minnesota to do a PhD in 2019 and have been working my way through that while doing some clinical work at the same time. So today I just want to give you an introduction to what physical therapists do. I don't have anything to disclose aside from the fact that I'm a PT, so that bias is going to be shining through. And I fully recognize that that causes me to see things in a very narrow lens. So I welcome the conversation and being shown other aspects of this world as well. So I want to help give you a window into how PTs think, because we do approach classification and diagnosis a little bit differently. We arrive at the same conclusions, but the way, as you're collaborating with and working with PTs, it is helpful to understand that we're not just technicians who, you write out your order and tell us what to do. PTs actually have a comprehensive diagnosis strategy, and I'd like to show that to you today. We'll talk a little bit about what we see in the evidence, but then I also want to give some real-life examples from my clinic about what this actually looks like, because it's really easy to say multidisciplinary collaboration and leave it at that. And I'm very spoiled because I work next door in the next office with some dentists, but it's hard sometimes to conceptualize what that actually means. So my intention is really to help you learn some things that you can take home with you and not just understand it in the context of an academic setting. So this is my outline of how I'll be approaching things today, and we will do question and answer session at the very end. So this is actually a word cloud that was developed by a group of orofacial pain specialist dentists about what PT actually is. And the official official definition of what PTs are, this is taken from the American Physical Therapy Association website. We're movement experts, and we focus on quality of life. So our interventions, exercise, manual therapy, modalities, education, we're all designed to help improve quality of life by looking at how people move. So how do we actually manage patients with orofacial pain? This is an example, at least, of how I approach PT evaluation, and most physical therapists you're going to see aspects that are similar to this. One thing I really want to highlight here is that physical therapists do screen for red flags, differential diagnoses, because most states now have direct access to physical therapy where patients can walk in off the street and self-diagnose, I think I need to go see a PT for this, that, or the other thing. Therefore, all physical therapy training programs are now at the doctoral level, and they've added elements, understanding about medications and neural anatomy and physiology so that we know how to refer. So this doesn't mean that PTs think that they're going to treat all of these different conditions, but we have that knowledge and understanding to say this person needs to see a sleep specialist, this person needs to go see a neurologist. So with direct access, meaning we don't necessarily need a referral from a provider for people to see us, that then we'll bring people into our clinic and we will identify now, okay, this person needs an orofacial pain specialist dentist. So that's why it's really nice to have relationships with other providers as well, because we can make your life a whole lot easier. So our objective testing is very similar to what dentists will test with measuring range of motion. We will also look a lot at quality of movement. Is it symmetrical? Is there noise? What could this noise mean? And then we will also be doing a cervical spine assessment because we know that there's this overlap between cervical pain and headaches. The sound reduction objective testing, I'm not sure if you have heard much about that, but essentially we will do some different tests that look at by whether it's protrusion, end-to-end positioning, putting some tongue depressors between the teeth and changing how they close. Does that affect the clicking? Things like that. So here's my really oversimplified schematic of how I approach classification. We do not currently have a clinical practice guideline for physical therapy about how to diagnose and treat temporomandibular disorders. So right now there is a lot of variation out there. If you do a Google search, and you'll see a lot of different continuing ed opportunities for PTs with different things across the board that may or may not be evidence-based. So there's a group of us working on creating a clinical practice guideline to standardize that. So hopefully by March 2024, we will have a document out there that will be used as the basis for PT education with understanding here are the recommendations about how we diagnose and classify patients for probably not the wide range of orofacial pain, but for sure temporomandibular disorders, and then evidence-based recommendations for treatment. But when I go through my assessment with patients, the first question I have is, are they falling into the mobility deficit category? They're not opening their jaw far enough. Or they're opening their jaw far enough, but there are some things that show me within their movement pattern that there are some deficits of coordination. And from there, then we will follow down and say how much of this is due to joint or muscle or both. And then there's an added level of neuropathic pain, which PTs aren't quite as used to looking at, but especially one of the talks that I heard yesterday was showing that we definitely need to start looking at that realm as well because of all the complex presentations that we see with neuropathic pain. And then also the existence of a headache that can be attributed to TMD will frequently overlap a lot of those pieces. And when we've identified, so for example, a neurologist will refer a patient to me because they've done all of the standard migraine treatments, all of the other pharmacological injection-based interventions, and their patient is still having a headache. And then they're hoping to see perhaps if we can do some PT that those headaches will get better. And we're hoping that we can actually start to shift it to be the other way around because it's a lot simpler to do interventions from a PT standpoint that can help with TMD and see that your headache gets better than to run through all of the list of medications and other types of treatments first and then land on the self-care and exercises. So physical therapists do follow the diagnostic criteria for TMD, the publication from 2014 that then splits it into those different conditions. We use our movement-based classification, getting down to see the level joint versus muscle, and then from there we will come up with our assessment or diagnosis that it follows the DCTMD. So disc displacement conditions, arthralgia, myalgia. We know we can't officially diagnose degenerative joint disease unless we have a scan. I'm spoiled because my patients are frequently getting the CBCT or MRI scans and sometimes coming to me already with the diagnosis. But that doesn't necessarily change how we treat someone. So we are not going to say this person has disc displacement with reduction, therefore we do XYZ. We look at there is the mobility deficit, we know there's a joint component and a muscle component, and we select our interventions from there. But it does overlap with that pathoanatomic paradigm that we see in the dental community. So this is, I think, a little clearer representation of how our paradigm aligns with the DCTMD. So on the left side, there's the realm of coordination deficits, and we can have just a joint-based deficit. That would be, for example, if someone has disc displacement with reduction, they're opening to 43, 45 millimeters, but they've got a significant S curve or a C curve, and they've got the clicking. It can be primarily joint-based, but those muscles are connected to the joint. So very rarely do I see somebody who is only having some sort of joint diagnosis who doesn't have muscles also causing some pain, because those muscles will respond to these patterns and adapt over time. And I actually tend to see that's where a lot of the pain-based conditions are coming from, is how those muscles have been reacting to their joint condition. We know that people then can go back and forth between these classification structures. So you have someone who's disc displacement with reduction, and then all of a sudden they catch, they've got intermittent locking. So then they're jumping over to that mobility deficit category, where they can't open all the way. And people can freely move back and forth between these two classification categories, but we will be using some different interventions based on what we identify is the primary limitation. So then over on the mobility deficit side, that's where I'll see people who have restriction because of trismus or muscle spasms, the closed lock people, some of the arthritic types of conditions, they're restricted. Post-operative patients will come in definitely restricted with mobility, things like that. And then, as I mentioned before, that the concept of the TMD headache can overlay, of course, all of the different categories. So what does our evidence say? And across the board, the evidence is just not good quality. What I've presented here, this is all systematic review, some meta-analysis information. The challenge is that they find that most of the interventions improve outcomes for patients. So it's really difficult for us to go through and say exactly which specific exercises or manual techniques. You come to a conference like this and you listen to people talk. Every single PT here has their own approach and strategy of things that work. And our research doesn't show that there's any one single best way to do it, because it's also very therapist-based. So there's some research out there about the concept of therapeutic alliance, which you may have heard of, but it essentially looks at the interaction between the provider and the patient, showing that in many cases, patients who have a positive sense of their interaction, they feel cared for, they feel listened to, will report decreased pain and better outcomes than somebody who does not have that positive interaction, but they're actually doing things that the literature has said is beneficial and helpful. So how I interact with my patient might actually have more to do with their improvement over time than exactly what I'm doing. So that's really difficult for us to look at from a research perspective and say, okay, therefore these are the things that you have to do. Then the outcomes tend to be conservative, non-invasive management needs to be prioritized first. I have one study referenced there, but that is not the only study. Many studies come out and say education and self-care are incredibly helpful and sometimes are the only intervention that is needed in order for people to get better in some cases. So we always make sure that we include that, of course. The studies that look at manual therapy, in general, manual therapy, so that means soft tissue mobilization, manipulations, massage, things like that are designed to try and release muscle tension in order to change movement. So it has been shown to be somewhat effective for all kinds of TMD. So the muscular, the joint-based, as well as mixed TMD. But then this review from 2020 did show that long-term manual therapy by itself isn't necessarily helpful. So people will be better for a while, but when you combine it together with exercise, that's what makes it most effective. When you look at the realm of exercises, again, it's very difficult because none of the studies really define exercise very well. Sometimes they'll show pictures, but 3 different PTs will have people doing stretches differently. But when they look at the realm of exercise, the review from 2021 by Zhang et al. Found that there was no difference between exercise and splint therapy. They actually ended up concluding that using them together was the best option. And exercises themselves are rarely ever applied in isolation. So physical therapy is considered, you're giving multimodal therapies. In fact, it would be pretty bad if a PT only did one exercise or exercise without education and manual therapy and dry needling or modalities or things like that. So that's generally what the literature shows. Don't just do exercise. But this last review from 2017 that I've listed, they did find that exercise significantly decreased pain and improved jaw mobility. Interestingly, in this review, they did not find that exercise had a significant impact on improving function, but they did find that it was associated with decreasing pain and improving mobility. So has anybody here heard of this study, Dr. Schiffman's closed lock study? PTs got really excited about this. I feel like this was one of the things that helped to bring us, well, okay, I'm at the University of Minnesota and Schiffman's at Minnesota, so there's a big reason too why we were paying attention to this. But in this study, they took, and I still can't believe that they got people to agree to be randomized to one of these 4 different groups. But they had people who were diagnosed with disc displacement without reduction, and they had 29 patients in just the medical management group, where they essentially had medication as well as exercise, education about their condition, ways to manage themselves. 23 people in the rehab group, so that was medical management plus rehab. They added physical therapy. And then they had 23 people in the arthroscopy group plus physical therapy, so it was all additive. And then they had a more invasive surgery, the arthroplasty plus PT, 21 people, and that's where they were doing either the disc repositioning or removal. And they found that, didn't mean to do that. They found all groups significantly improved and that they had no specific difference between groups. Now, no difference between groups does not mean that these treatments are all equivalent. There's very specific statistical testing that you can do in order to look at equivalency, but there's no evidence that any one treatment was better than the others. And the important conclusion that came from this study, again, this is just the disc displacement without reduction population, but their conclusion was start with the conservative, cost-effective strategies first. And as a result, actually, at the University of Minnesota now, our oral surgeons won't even have a surgical consult with people until they've had 6 sessions of physical therapy. It doesn't have to be physical therapy, but the idea is that people should try the medical management and, if possible, even the rehab strategies first before they start doing surgeries. Of course, there are always exceptions. There are always exceptions. But this study was one of those big things that started to bring that into the forefront. So my catchphrase here, TMD is a problem to be managed, not fixed. Of course, there are some things that we can fix, but the point here is that if a patient perceives that they need things done to them to get fixed, they are not going to maintain that improvement going forward. So what I mean by management here is that we are combining elements of passive therapy and active therapy. Passive therapy, something is done to you or to the patient, submissive recipient, as opposed to the active therapy where patient is actually doing things themselves. So there are definitely applications for passive therapy, especially with acute pain. This is where we'll do our massage, soft tissue mobilization, dry needling, manipulations. This is good for short-term pain management. The active therapy is what we need in order for things to get better for the long term. So there is actually no evidence that passive therapy helps chronic pain. But in this active therapy, we have self-massage, self-care, doing exercises, doing stretches. And this study from 2014 was fascinating because they took people with chronic idiopathic neck pain and scapular dysfunction. And they had PTs passively putting their shoulder blade into the right position versus the patient actively performing it themselves. And only the patients in the active scapular correction group had any decrease in pain and pressure sensitivity on a significant level at the closest painful cervical spine segment. So hearing that makes sense. If someone's putting your scapula in another position, then why would you expect your body to maintain that? But people expect that. So people expect that if you go in and you get a massage or they correct your first rib, that it will stay fixed. And it doesn't, because our muscles have adapted based on how we use ourselves, how we move, what our habits are. And if that element doesn't change, it doesn't matter how many times somebody else puts it in a position that feels better, it's not going to last. So we need elements of both, and therefore our physical therapy plan of care will combine these passive and active therapies, and our goals do include independent management for discharge. Patients need to be doing things for themselves going on in order to get better. So my thought process, and most PTs, when we're designing our plan of care, clearly we are helping to manage pain and inflammation. We're always doing those elements of education to help people understand what's happening to them and why. From a movement standpoint, we're going to look at restoring that straight, controlled jaw opening, making sure we get the posture upright so that we're decreasing strain on the jaw and neck muscles, and also looking at those cervical deficits and muscle pain. Because one of the best ways to undo all the really great work you do with your jaw is to sit with forward head posture all the time and put all the strain on your neck muscles and pulling, changing the forces on the jaw. It's a really delicate balance with the mandible and the cranium and the neck. Our necks are really skinny based on how big our heads are. So from a classification specific standpoint, for me, again, I'm looking through joint versus muscle, and I'll select my interventions, possibly modalities accordingly. How irritable are they? If they're highly irritable, that's going to change. I'm not going to go in there and use the same amount of manual force with them as I am for somebody who doesn't have a whole lot of pain, but maybe they do have that really hypomobile capsule, and we can just get in there and mobilize the heck out of it. One thing with restricted mobility, we always want to make sure that we're restoring lateral protrusion, because that gives us information about the pterygoid function. We need those pterygoids to get our full opening. So personally, I never push patients to go much above 30 millimeters unless we've got adequate lateral protrusion, range of motion, and pterygoid control. And then for those motor coordination deficits, these are the people, they're already opening really well. So if we stretch them, it may actually cause some problems because they have to keep using that faulty movement pattern in order to get far enough to feel some kind of a stretch. So we're looking more at, again, restoring that straight opening, controlling maximum opening, making sure we're stabilizing the joint as opposed to stretching and getting it mobile again. Has anyone heard of the Rockabato 6x6 exercises? Yes. Okay. There's actually really very poor to no literature evidence that 6x6 as a unit works. What I love about it is the focus on relaxation, retraining. The 6 repetitions 6 times a day gets us away from the idea of, okay, I'm going to do my 30 minutes of exercise and I'm just going to go back to using myself the way I do for the rest of the day. Maybe I'll come back to it at night before I go to bed. But our habits occur because of things we're doing subconsciously throughout the day. So I really push that for my patients because it's very different from our traditional orthopedic approach to physical therapy. If you're rehabbing after surgery and you have to get down on the floor, it's really hard. You're not going to do that 6 times a day. But if we're talking about how we use our jaw subconsciously, it needs to be broken down morning, afternoon, evening, or around meal times or things like that when you're actually using your jaw. So that's the piece from the Rockabato 6x6 that I really like. But it was actually Dr. Millett who did a study and looked at having patients do the 6x6 exercises and found, I think they only looked at 4 weeks, but adding the 6x6 didn't make a significant difference. Most PTs are just going to select these as needed. So they'll be using scapular retraction or they'll be doing controlled jaw rotation, opening and closing, but they're not going to just give them a sheet with the 6 exercises and then kick them out the door. So I just wanted to talk about that because Rockabato is a really big name and an innovator who was one of the first people to suggest that we can use exercises in some of this retraining. And then our profession has continued to evolve beyond that. So we see much more benefit if we're using components of this and that concept of habit reversal throughout the day. I just want to quickly, let's see, my time ends at 11:25, is that correct? Is that okay? So I'm not going to go through and teach each one of these exercises. The scapular adduction is bringing your shoulders down and back. Stabilized head over neck flexion is just nodding your head on top of your spine, whereas axial extension is bringing your head all the way back where you're starting to get upper cervical extension at the end range of that. I will highlight controlled rotation as my favorite exercise, and almost every single one of my patients is doing that. So I am going to take you through that one very quickly. If you just palpate your condyles right in front of your ear, first of all, to notice what happens when you open wide, go ahead and open and appreciate how the condyle is translating forward. Your fingers fall into that little hole. You may find one moving earlier than another. You may have a click. But for controlled rotation, we're inhibiting the pterygoids. So you put your tongue on the roof of the mouth, and you open with your chin down and back in the tongue up range. So you are eliminating translation. Can you feel the difference without your condyles coming forward? This is how we start patients learning how to inhibit that early translation that might be getting them to click and pop or translate in a faulty way, and then we build from there. And then finally, the rhythmic stabilization is isometrics, side to side, up and down, and you're actually creating some reciprocal inhibition for the pterygoids as well as then the masseters and then some of those digastric muscles too. So when I have a hypomobile patient, that's where I'm going to be using jaw stretching. Dr. Peck was talking about this a little bit earlier today with the fingers and the knuckles. The picture on the top right is me doing joint mobilizations, but PTs will be doing any elements of what you see listed here in order to help improve range of motion. And then motor coordination deficits, again, the difference here is that we're not stretching, we're not pushing for range of motion. We'll be teaching people how to limit opening with that tongue up strategy. If they are subluxing, we teach them the self-mobilization to unlock. You know, from a mechanical standpoint, helping them to understand what's actually happening takes away a lot of the fear. So joint protection and relaxation training. And then we again use exercises to try and help look at the rest of the system. What could possibly push them to the point where they're going to be shifting their jaw and clicking and popping. That isokinetic resistance exercise means that you're moving against just a little bit of finger pressure, which can help to maintain some of that coordination and control between the pterygoids. And that study from way back 93 now is pretty old, but they found that 85% reduction of joint noises happened in young adults when they were doing resisted lateral protrusion to about 1 fingertip's width away from the side with the click. So what we're doing there is we're helping the muscles retrain and helping the body to adapt. They're usually clicking in the first place because that disc has adapted, the ligament has stretched out. We still have that adaptive capacity. We can retrain the body to move with stability within that context. So helping patients also understand that your disc being displaced is not a scary mechanical situation. It's your body adapting to use. I have very few patients in my practice who have a traumatic disc displacement from car accident or something along those lines. So I look at these as overuse injuries. And then finally, isometric strengthening at varying stage of opening. That's helping people to have control no matter where they are. So I'll take them just to the point where they're going to have to deviate and make sure that they have good strength and stability there, so then we can move them beyond that and maintain that stability. A short note about modalities. So back in the 50s, PTs were known as ultrasound and massage technicians. Again, we're moving beyond it. The literature evidence for ultrasound is terrible. There are a few studies recently that are starting to show that maybe there's the potential to help with arthritis. Maybe we'll have to see what we come up with in the clinical practice guideline. A lot of PTs are just throwing those ultrasound machines out the window because there is really no literature evidence that it's helpful. I find it to almost be more placebo effect for people. When you're doing ultrasound, they think something is being done to them that feels really great. They're actually getting more of that autonomic nervous system change. There is some literature evidence for low-level laser therapy, so you'll be hearing more about that. I know of a lot of PTs here who do use laser in their practice. We don't have one at the University of Minnesota, but once the guideline comes out, maybe that'll change. TENS units, insurance companies don't pay for them the way they used to. They are really helpful for home management. So some chronic pain patients, it's the gate control theory of essentially disrupting those sensory receptors so that you don't notice the pain quite so much. We have an intraoral electrogalvanic stimulation unit at our clinic. This is not common. Most PTs clinics won't have that. That's the picture on the upper left. But we can actually use a probe and get close to the lateral pterygoid area, intraoral masseter, and then even the medial pterygoid to help if you've got a muscle spasm after needle injury from dentist procedure or something like that. And then there is some evidence that iontophoresis can help decrease inflammation in the joint. And for that, we do need a prescription from the dentist for dexamethasone with the parameters listed there, so they bring it in. Pharmacies really seem to be having a hard time understanding how to prescribe this lately, but iontophoresis can be helpful. We need to do 6 sessions for that in order to start seeing some effectiveness, and there are starting to be some home ionto applications, so you put it on a patch, you put it on, and then they can go home with it too. Anyone heard of dry needling or had it done to them? Yes. So literature evidence is definitely growing, and it can be a really helpful way to decrease muscle tension and pain. That's a picture of me getting my lateral pterygoid needled. I don't do it personally. I'm in the middle of my PhD, and I'm focusing on that training right now, so someday I may get certified. But a lot of PTs are starting to do this, and there's really some strong evidence about it helping with orofacial pain. So our goals are helping people get back to their life. It's fairly intuitive, but we need people to meet these goals in order to discharge them, so they're not coming in indefinitely. That independence with the home exercise program is definitely what we're after. As I said before, we are helping them learn how to manage themselves. So great, this is all fine and good. I'm going to go through some examples of some of my patients, low, moderate, and high complexity, just to show how this works. What does this look like? So my first patient here is a woman who'd had 2-year history of pain, not very intense, definitely related to function, but she could tell that she just couldn't quite get it under control, and it was getting worse over time. She had some clicking and catching, some history of trauma with the car accident. It didn't seem to be especially significant, but it was there in her history. This woman lived about 3 hours away from the clinic, and she did not have a PT nearby. So the dentist at our clinic suggested, how about some telerehab with our PT? They did recommend pain psychology for her, but she decided she just wanted to start with physical therapy. They thought, okay, maybe we'll do a splint at some point, but started her with self-care. And then they referred her to me for an evaluation, which we did virtually, and she was showing only about 30 millimeters of that pain-free, noise-free opening, but she could open all the way to 48 millimeters. She did show some deviation, some clicking on the opposite side, a little bit of crepitus, and then self-palpation. So when I do telerehab, I guide people. I show them a picture, where to push, cue them how hard to push. We'll say enough pressure to blanch your fingernail. Hold that for about 3 or 4 seconds. And then I write down what they report. So looking through this classification category, yeah, pain-free, she's limited, but she can push all the way open. So then she falls more into that motor coordination deficit category with some joint and muscle involvement. And her more official diagnosis, according to the DCTMD, then is the bilateral TMJ reducing disc displacement with some masticatory muscle myalgia. So what did we do? I taught her the controlled opening, the one that I just had you do, my favorite exercise, teaching her how to move within that stabilized range of motion. And then we did progress with exercises to increase the range of motion without allowing it to shift or click, reprogramming the good stabilized opening. I taught her relaxation, self-massage exercises. So we're going to go through one very quickly here. Feel your muscles. Think about, are they hard or soft? A relaxed muscle should feel like raw meat, which is really gross. So then I'll say marshmallows or bread dough. Imagine you're kneading bread dough in your face. Let that tongue float up toward the roof of the mouth, taking a breath. Nice big exhale. Lightly pull your hands down the sides of your face. Let your lips go. Let your face go. Your goal is to help your system release that muscle tension from the inside out. None of us are actually strong enough to do deep trigger point release to force those muscles to let go. So that quick little strategy, even just dropping it by 1%, patients can do that on and off all day long whenever they start to catch themselves tensing and clenching. So I can also teach deep trigger point intraoral massage for people. We didn't need to for her. That was basically what she did. She did some neck massage too. For her, recognizing triggers, developing coping strategies to release tension was a big one. And then she did end up getting a splint from our orofacial pain specialist after 3 weeks. By week 6, 3 sessions of virtual PT, she had met all of her short-term goals. She was back to opening 48 millimeters straight, no click. And the quality of life scale score had already improved by 9 points, and we know that we need at least 6.7 points of improvement in order to be significant. So we only did 5 sessions over 3 months, so there's time in between those sessions. She was discharged to independent management, met all her long-term goals, ended up with 55 millimeters of opening, 98% overall improvement. And then she had a follow-up visit 6 weeks after that with our dentist. She was still doing all of her exercises and self-care, still said 98% overall improvement, and then they're going to have her come back in a year to check her splint. So, really easy example. Let's move on to a more moderate complexity patient. So this lovely woman had so many fractured and broken teeth. It looked like she had been through some sort of an altercation. 4 years history of repetitive fillings, extractions, restorations, severe periodontitis, localized bone loss and necrosis. And so actually from a prosthodontic standpoint, she was extremely high complexity, but ended up only being about moderate complexity for us once we had multidisciplinary care. But just her years of prosthodontic care was starting to create pain and restriction of range of motion. Her condyles were starting to flatten, developing osteophytes. She also had some concurrent diagnoses of depression, anxiety, and ADHD. So the prosthodontist was the one who actually first identified the joint changes and the limited opening, some traumatic occlusion, said, all right, got to get you over to the orofacial pain clinic. Our specialist dentist saw her first, noticed that jaw and neck pain was present. She had some restricted opening. They instructed her with self-care and PT and then sent her over to me. So pain-free opening, I have people open in a range without pain or clicking, because to me that indicates where their body's preferred level of function is. It's only 18 millimeters. And her neck was pretty restricted, a lot of clenching habits. So she for sure fell into that mobility deficit category with diagnosed degenerative joint disease per CBCT and muscle pain. So I saw her once a week for 6 weeks, talked about a lot of those same things, habit awareness, heat use. I did do some ultrasound with her of that anxiety aspect for her. I think the placebo effect of the ultrasound is what helped her to calm down. Manual joint distraction, stretching. The picture on the lower right, that's a more passive stretch I'll have people do to themselves where they widen their fingertips between their teeth. She was able then to get to the point where she got through 2 more of her dental restoration visits with minimal pain. She was so excited because it had been so long since she was able to tolerate those visits, and we were able to taper back. So then we did 1 visit per month for 6 months, and we would time it right before her visits with the prosthodontist. And then we ended up doing 12 visits over a year. So more frequent at the beginning and then tapered back for those last 6 months. She kind of plateaued in terms of range of motion at 6 weeks, but her pain was down. She had met all of her goals. By the year follow-up, she'd met all of those long-term goals, eventually getting to 38 millimeters pain-free and 40 total. And then as I was writing up these slides, I looked and saw she'd had 2 additional implant procedures since my last visit with her, and she has not reached out to me saying that she needs care. So that ended up really working out well. Our last, the high complexity patient, oromandibular dystonia. So when she would try to talk, she would start clenching. And the more she talked, the more she sounded like this. She had a phone job, customer service. People were screaming at her all the time. And so I think there was a high element, too, of the psychosocial component. She had this mouth guard she was wearing. She couldn't talk unless she had that mouth guard in because it would help disrupt some of those signals. She had tried everything. She was starting to actually seek out some of these invasive, irreversible treatments online because she didn't know what to do. She'd done all the traditional dystonia types of treatments, Botox injections, nothing was helpful. So our dentist, they made her a new splint, started her with all the traditional things, referred her to the health psychology, pain psychology, and PT. Her range of motion was fine. Her lateral protrusion was a little weak on the left side, but she definitely had some faulty movement patterns, and that clenching limited her talking. So for sure, the motor coordination deficit element. She did also work with a pain psychologist. They identified a trauma history, diagnosed PTSD. So that was an important piece of her care. We did PT once a week for 6 weeks. We ended up doing a lot of coordination work with a little rubber tube that she would have between her teeth. It got to the point with that tube in between her teeth, she could talk completely normally. She just needed something to help disrupt some of those, the perception and the proprioception. That's the word I'm looking for. She improved the proprioception and was able to help control that. And that health psychology intervention, like we heard about from Dr. Boguero, was really important and helpful. She still didn't recognize the importance of it by the end, but it wasn't until she started working with the health psychologist that we started seeing those long-term changes. She was also working with an acupuncturist. She had Botox injections, and it worsened her partway through. And that was when she said, all right, I'm done with that. I'm just going to focus on these other pieces here. So we ended up having 20 visits over 11 months. And with discharge, she could talk normally unless she was stressed. And then putting that little tube between her teeth would disrupt the dystonia. She still had someone, a chiropractor, and I think worked with her acupuncturist for some manual interventions. But she still does her exercises. She reached out to me asking for, where can I buy more of the rubber tubing recently, but otherwise said things are going well. And so then she's also doing a mouth guard, so. All right, I know I'm over time. I'm sorry. I only have a few more slides, but these are the important take-home ones. Again, patients can come see PTs on their own in most states. They don't need a referral, but if you're talking about it with your patients, it's covered by medical insurance, not dental. You can definitely, please, share your diagnosis with PTs and anything that you have found. If you want them to do Ionto, we do need that prescription. But Make sure you communicate with your PT. And if they're a Medicare patient, the primary care provider actually needs to sign their plan of care, needs to look at and sign their plan of care. But aside from that, the PT will be communicating with you if you refer them with progress notes. So then the more important question that I always get is, okay, I don't have any PTs in my area who treat TMD. So my suggestion there is to go to the PTBCCT.org website. That's our PT group here, kind of under the umbrella of the AAOP. There is a member directory. So then if you click on the top of that member directory, it'll bring up all of the certified CCTTs. Actually, it's around the world. And then you can also search by state. So this is me and Dr. Leslie Hubda. We're the 2 certified CCTTs in Minnesota. So this is a great first step. Okay, so there really aren't any PTs in my area who treat TMD. Find a CCTT close by, say, okay, who do you know in this area? But there are lots of PTs who treat TMD who haven't undergone the testing. So call a clinic and just ask. Does anybody specialize in this as a special interest piece? And then also just know that by the time we get that clinical practice guideline, there will be standardized recommendations. So when you refer to a PT for TMD, any PT with a license should know that they can treat these things. People are just scared of it. So we're getting that knowledge out there. And then we will be doing questions later in the Q&A session. So thanks for your attention.